Good afternoon. This is the Thurston County Board of Health meeting. To my left, we have Gary Edwards, board member, Carolina Mejia, Dr. Beth Harvey, and Lynn Nelson. I call the meeting to order on Tuesday, May 9th, 2023 at 4:33 p.m. Does anyone call the meeting to order?
Do you want me to make a motion to
Yes,
approve
motion.
the agenda?
Yes, please. Sorry.
I would move to approve the agenda today, Tuesday, May 9th, 2023.
I'll second. Okay. First item on the agenda is the opportunity.
Call for the vote.
Oh, I'm sorry. Call for the vote.
Just do the general one, or do you want me to call?
Just-
Madam Chair, for the record, Commissioner Messrs join us via Zoom.
All those in favor, please?
Aye.
Aye.
Any opposed?
Aye.
First item on the agenda, opportunity for the public to address the board. And we have one person via Zoom. Prior to that, I'll go ahead and read the guidelines for the public. Please introduce yourself, including the address you reside in the county. Please address the board, not the audience or the staff. Please silence your cell phones. The board does not respond to public comment. On a need basis, the county manager will follow up with specific items. Speaker will be limited to 4 minutes to address the board. Meeting attendees cannot donate their speaking time to another person. The board reserves the right to restrict a person's opportunity to address the meeting for a good cause. No comments that are lewd and offensive, inflammatory, hateful, defamatory, or discriminatory in nature. Please be respectful. No outburst of any kind. No comments that are commercial in nature, such as promotion for a for-profit business. All materials provided to the county may be considered public records, subject to public release upon request pursuant to Public Records Act, Chapter 42.56 RCW. No remarks about pending land use permits or similar matters that could eventually come before the board on appeal. Thank you for your cooperation. I believe we have Darlene Atkins via Zoom.
I'm here.
Oh, you're here. Okay, I'm sorry. Yes, please.
Good afternoon, everyone. I want to say thank you all for being here and also for this wonderful group behind me, the nurses.
Ma'am, for the record, can you
Oh,
introduce
sure.
yourself and where you reside in the county?
I'm sorry.
Thank you,
My name is Darlene Atkins. I'm a Tumwater resident.
thank you.
And I'm sorry, I gave a public comment earlier today, so I might think this is just an extension of that, and everybody knows who I am. So I'm here today because I've had a call to action. I didn't start today. It started a while ago, and I've sort of been making the rounds in the county to school boards and then online with the library trustees. And it's about health and well-being. So I've served in the military. I work for the federal government as a health readiness coordinator. So I'm in and around, stressful situations quite a bit. But even in the military, there are several initiatives about being proactive with soldiers' welfare and care. And we have a resiliency program, and I've been through that. And I waited many years in the military for something like that, instead of always taking care of things after the fact or when there's crises. So what I've been doing is discussing with school boards about the idea of a brain science curriculum tweak. So thankfully, me, without big credentials, is not the only person. I'm not the only entity making this pitch. Even Goldie Hawn, an actress who wanted to reduce suicides among young people, with her money and her foundation, partnered with Scholastic in order to teach brain science to children. But there are others with credentials. Dr. Eric Chudler at UW's neuroscience department. He has a newsletter, Neuroscience for Kids. They also had a big event Friday night, and I was in attendance. We looked at a brain dissection quickly, not a lot of time for that. And they had a panel of a variety of people, not all neuroscientists. One was a brain surgeon, one was a sociologist, who wanted to look at the intersection of, the equity and race issues from a neuroscience perspective. So there's all kinds of applications for our society today if we incorporate more of a focus in prioritizing neuroscience in the classroom. But starting young with those young brains that are absorbing things and loving to learn, not starting at, say, 55 or 65 when you're afraid of getting dementia. My mother had dementia, and I went through that process with her until she died. I would have thrived, I just know it, with not only SEL, which thankfully is being incorporated, social emotional learning, but also this brain science tweak. And that takes out the ambiguity when you add the brain science, because children, and they have wonderful lessons that start in preschool up through elementary and on for children about discussing what is the amygdala, what is the prefrontal cortex, how do we calm our brains down. Now, can you imagine a world where we wake up in the morning and we're not dreading to go to work, but we have young people who are getting up and they're taking their moment of some nice breaths. They're doing their routine that's good for the brain. They're doing a little bit of exercises, and they're going out there not worrying about whether there's going to be mass shootings or illness or so forth. So I asked the Department of Health to help me with this campaign. Thank you.
Thank you. Is there anyone else that's not on the list? We move to our second item on the agenda, which is a proclamation that.
Maybe I have somebody in Zoom.
Oh, you do? Okay.
I have a phone number with the last four digits of 0300. If you'd like to provide public testimony before the Board of Health, please unmute yourself, introduce yourself, where you reside in the county. You have 4 minutes.
Hi, can you hear me? This is Carolyn Jurgens. Hello?
Yeah, go ahead. You have 4 minutes, ma'am.
Wonderful, thank you. Right, so yes, dear members of the Thurston County Board of Health, I was hoping to deliver these comments in person this evening, but as many parents can sympathize, I'm going to be running carpool to soccer tryouts shortly, and I'm not going to have adequate Wi-Fi. So I'm writing you today, or speaking to you today as a concerned mother who's advocating on behalf of her children who have been impacted by the recent school closure last week at St. Michael's School under the guidance of the Thurston County Health Officer, Dr. Abdel Malik. Despite the fact that our state's emergency powers ended October 31st last year, our schools somehow found themselves under what they consider the legal requirements of the letter of recommendation dated May 2nd from Dr. Abdel Malik to our school doctor. By our school's interpretation of this letter, they are required to enforce a 10-day mitigation policy, which includes mandatory testing and masking for the entire classrooms of asymptomatic kids. As we understand it, the parents, this decision is the discretion of your department. It seems unreasonable that given our present circumstances, knowing that on April 3rd, the Washington State Healthcare ended the mask mandate, on May 5th, World Health Organization declared an end to the pandemic, and on May 11th, all remaining U.S. federal orders are set to expire, that you would require healthy asymptomatic kids to cover their beautiful faces in the classroom all day, all week, and subject them to mandatory testing. Again, these are 8 and 11-year-olds. Also protect them from a virus that poses no danger to them or their teachers, all of whom have access to recommended vaccines and therapeutics. Statistically speaking, the virus is clearly of little present danger and also endemic. Like many of the recurring annual viruses in our community, like the flu, norovirus, or other coronaviruses, the COVID-19 virus is no present emergency. Clearly not to a school of children whose immune systems will be stronger from having fought it off. It clearly doesn't warrant the requirement of these mitigation measures that are not appropriate given what we now know about the virus itself. What are we doing this to stop the spread of what exactly? How can this currently be justified? Now, I should clarify, if our school misinterpreted the letter, and if it was in fact a recommendation only, and they are under no law to enforce it as a requirement on the school, but rather to take the recommendation of Dr. A under strong advisement, then please offer that clarification today. Otherwise, I implore you to unmask our healthy children. They don't deserve to pay the price this week to follow through with guidance that has now become obsolete. I urge you to remove this requirement for mandatory masking for our 2nd and 5th grade children at St. Michael's School this week. Respectfully submitted. Thank you.
Thank you. Let me check, Mr. Mark Boyer, would like to provide testimony this afternoon?
Yes, thank you. Can everybody hear me okay?
Yeah, yes, go ahead,
Great.
sir, you have 4 minutes.
Yeah, my name is Mark Boyer. I reside in Olympia, Washington. I as well am a parent of 3 children that attend St. Michael's School, and 2 of which are in the classrooms that are now enforcing these policies that Carolyn just spoke of. And my comment today is to echo pretty much exactly what Carolyn just said. And, you know, I can't help but notice, at least those that are sitting on the panel there on Zoom, that there's not a single person wearing a mask. And I would just ask why our children are still subjected to these measures when the rest of the world, for the most part, has recognized that those are options that are available to individuals, but not something that should be required. I believe that we've learned a ton over the last 3 years. There have been numerous original advocates of masking that have come out and talked about the effectiveness, and so I'm not here to argue that. What I'm here to argue is for common sense and swift action. You know, I recognize that some things are still moving, and that COVID has been a moving target for a lot of agencies, and the speed at which you change course is not always maybe the speed that we would like to see. But here we are 3 years after the start of the pandemic. We now know that it's endemic, that all of the things that we've been battling for 3 years are behind us. It's really hard to understand why our children are now being subjected to this again. And to question the common sense even further, it's just the 2 classrooms. It's not even the entire school. So you have unmasked children next door to a classroom full of masked kids. And I would just ask all of you, does that make sense? Is that the reality that we now have to live in for the rest of our lives? And I don't believe it needs to be. I think our kids have shown resilience to the virus, that their immune systems have been affected in a negative way for trying to avoid this for 3 years. If you talk to nurses and teachers and parents alike, the last couple of winters have been really difficult for basic viruses that our children are fighting. So I truly believe that our kids are healthier without masks, and I would ask that all of you look at this immediately, question why still in the schools but nowhere else, and move to act as fast as possible. Thank you.
Thank you, sir. And I believe that concludes public testimony.
Thank you.
You want to ask if anybody in the audience?
Is there anyone in the audience that has any further comment? Next item on the agenda, proclamation for National Nurses Week proclamation.
Good afternoon, Board of Health members. My name is Gretchen Toller, and I'm the Division Director for Community Wellness at Public Health and Social Services. I'd like to welcome our school nurse partners from North Thurston and Tumwater School Districts, as well as our maternal child health, nurse family partnership, and disease control and prevention nurses. Nurses are the backbone of healthcare. They are creative, innovative, intelligent, trustworthy, supportive advocators, and so much more. The past few years of COVID have been very difficult. Nurses have been stretched to continuously step up to new challenges. Without hesitation, they have consistently supported efforts to improve the health of the community. Although we're moving out of the pandemic, our public health and school nurses are working with an increased severity of mental health concerns and other crises with children and families. They care deeply about the individuals, children, and families that they work with, and they're a trusted resource. Nurses bring a depth of knowledge and skill set that improve the health of our community. Their critical thinking, advocacy, and dedication make a difference every day. I'm honored to work alongside them, and I want to thank them for all that they do. I'd like to pass it over to Whitney Myers on Zoom, if possible. She's one of our supervisors.
Hi, my name is Whitney Myers, and I just wanted to thank you today for recognizing the impact that the nurses make on so many lives. They really reach people in the highest time of need, and we're just really grateful for the work that they do, and then also for your support of the community by supporting the programs and the nurses. So thank you all.
I'll just also introduce Lori Montoya. She's one of our other supervisors. And then we've got nurses from, like I said, North Thurston and Tumwater School Districts, and then also our nurses from Public Health here with us today. And that's it.
I'm sure they can come to the podium and say a few words.
They can. Would you like to come say it?
No pressure.
Fumi?
We'd love to hear from the nurses, yeah.
They're an amazing group, I will say that.
Absolutely.
Yeah, they work very, very hard, and yeah, like I said, I mean, we are facing new challenges right now, I think, coming out of the pandemic.
Thank you. We want to honor the nurses and provide a Thurston County proclamation for National Nurses Week, May 6th through May 12th, 2023. Whereas the week of May 6th through 12th, 2023 is National Nurses Week, with this year's theme being You Make a Difference, to honor nurses' varying roles as well as positive impact they have on every person's life. And whereas thousands of nurses work in Washington State, including nearly 84,000 registered nurses, licensed practical nurses, and advanced registered nurse practitioners, including staff nurses, nurse educators, school nurses, public health nurses, long-term care nurses, nurse managers, and nurses in many other practice areas.
And whereas Thurston County nurses represent the front line of disease prevention, health promotion, and achieving optimal health in most health systems, including public health, especially as we fight the global COVID-19 pandemic.
And whereas now more than ever, we need to support and recognize nurses for their contributions in crises and for their ongoing roles in meeting the needs of patients and their communities.
Whereas nurses are public health heroes who make our community safer and healthier and contribute to our community as advocates, educators, and providers of critical health services.
And whereas Thurston County nurses are committed to serving our community 365 days a year and support many vulnerable individuals and their families with a caring and competent presence. And whereas Thurston County nurses' contributions are considered crucial to the delivery of effective, high-quality care with positive, lasting outcomes.
And whereas nurses improve the quality of life in our communities through their tireless efforts to educate, support, and provide important resources to their patients.
Now, therefore, be it resolved, the Board of Health hereby proclaims May 6th through 12th, 2023 as Nurses Week in Thurston County and calls upon all residents, communities, government agencies, faith groups medical facilities, elected leaders, organizations, and businesses to celebrate nurses' accomplishments and efforts to improve the health of our residents and show our appreciation for Thurston County's nurses, not just during this week, but at every opportunity throughout the year.
County Manager, do you want to allow for comments, Chair? Especially since Chair Menser cannot be here, maybe allow for comments. Is that okay with?
Any comments?
Commissioner Mensah, any comments?
Thank you for calling on me. You know, obviously it's been a very difficult period of time recently. We've always appreciated our nurses, but it's just elevating and elevating that appreciation level as situation has become more and more difficult. And I've had personal experiences, unfortunately, in the last year of being cared for by nurses in hospitals, and I really appreciate that. So just a personal thank you to those folks that cared for me in both Yakima and Tacoma. But I know that in Thurston County, it's the same situation. We have great folks doing great work, and the challenges that we're facing, that we're going to talk about, I think, a little bit later in this meeting, are of no creation of that group of employees. This is something that we have to deal with at a systemic level, but they're there in the trenches doing the work, and I appreciate everything they're doing to help our community.
Okay.
Well said. All of you come to the front for a picture. Don't be shy. Okay, we come to the center. This way, this way. Go back. Right here, right behind that. Just in front of the, right. Keep going a little bit more. Oh, a little more. A little more.
You're pretty good director.
No, we need to capture the board members.
Sure.
Oh, yes. Yeah.
Don't we need an angle shot when we're here trying to?
Okay, one more, bear with me. Here we go. We're gonna Photoshop time. Thank you, everybody.
Thank you.
Wow, what a crew. Sorry, I'm not.
Oh my God. Oh my God. Thank you.
Next item on the list, we have Thurston County Healthcare System presentation from Ben Miller-Todd, Emergency Service Director.
Learned from watching the first time. Good afternoon, board members. My name is Ben Miller-Todd. I'm the Director of Emergency Services for Thurston County. We're going to be running through a couple of slides as we go through this, and I just wanted to take the opportunity to quickly call out that I get the pleasure of doing this presentation with two of our healthcare colleagues, as well as Director Bain from Public Health, as we go through this presentation. With that, please stop me and ask me questions that you have as we go along. There'll be quite a bit of data involved with this, but we'll make it digestible as we go through. So thank you. Going through this, a couple of the things that we've experienced and to understand some of the healthcare constraints in this county, we need to understand the population that we're serving. And some of those components that you can see behind me in terms of the data are that we're a growing community. In the last few years alone, we've grown 10.1%, and we're only going to continue to see that growth moving forward. As we go forward and we start looking at what that distribution looks like, I think that's the more important slide as we skip to the next one. We're seeing a top-heavy growth. So a couple of the things that I wanted to point out are that we're serving a community that's gradually aging. One of the things that, if you're looking at the slide deck in front of you, our median age in Washington State has grown from 29.8 years in 1980 to 37.3. And that's a testament to a lot of different components, actually, especially to public health themselves. We've improved the longevity. We're retiring later. We're not retiring later. We're not moving. We're not changing that. Let me clarify. However, we are living longer past retirement is the clarification. And with that, we're also having to serve that community. That community is also becoming more complex in terms of the service that's needed in the healthcare arena, both from the EMS perspective, the hospital segment, and also long-term care. And so when we're talking about this and we're looking at the continuum of care that's necessary in Thurston County, it's important to remember the distribution that we're serving. Our population has gained in age because of public health initiatives, and we're also growing in sheer volume as we're moving forward. So keep that in mind as we're walking through the presentation and understand the different components involved in what it takes to serve a community like Thurston County. And specifically for emergency services, we've seen an increase in call volume. Remember that I called out 10.1% was the population growth. Over a similar period of time, we've seen almost a 62% growth in our EMS call volume. That's something that's a testament to the population that needs more services. As we're seeing that growing bulge, when you're looking at that population, is now the red at the very top of that population density is quite large. It's almost equal to the population that's considered our working workforce. Our working age is almost a similar population, but those services are needed 3 and 4 times that just because we have a complex population to serve. Additionally, with that volume, we're seeing an increase in response times. As we're seeing more and more volume placed on the system, it takes us a little bit longer to get onto calls. And as we're going through that, we've seen a 12% increase alone in our response time just in our medic units between 2019 and 2021. A last component of this is that as we're talking through this, and the reason that I have our partners here with us to talk to it, is that it's been an ongoing, it's been a lot of things that have been highlighted by the pandemic over the last few years, that there were breaks and fissures and gaps along the way that were just highlighted and augmented throughout the pandemic. And so some of those components are being corrected as we talk through it from a public health side, and that we'll see a return to the norm, but there's also a component that's underlying, and you need to understand the population's changing and growing. When we're talking about wall times, and this is where something that EMS is very cognizant of, the resources it takes for us to serve a community are incumbent on us getting back into service. And if those EMS wall times are the time that you're waiting outside of a hospital. So if you drive up to any hospital, honestly, in Puget Sound, I cannot call out my partners, that it's any hospital. I'll be honest, any hospital from the Mexican border to the Canadian border is experiencing extraordinary wait times just to get into a bed in an ER. You've seen initiatives done by California looking to address that from a legislative aspect. And that's something that we're starting to track and see in our own community, some of those extended times that we're waiting just to offload our patients that are picked up at their residence and they go to their communities, or excuse me, if they go to their hospitals, they're waiting there for an hour, 2 hours, 3 hours, 4 hours, and our longest wait time just to offload to a hospital to date is 9 hours and 21 minutes. 9 hours. That's taking resources out of the communities that we're looking to serve. It's putting them outside of a hospital and for extended periods of time in which we're not able to respond to subsequent calls for service. And so a large component of that is working in conjunction, and we're going to talk about some of the initiatives where the hospitals have looked at partnering on how do we decompress that? How do we look to address and identify some of those components and look to really reduce what we've seen as an astronomical increase, as you can see in the graphs behind me, the time that it takes just to get a bed in the ER. And that's just the first part. So remember, this is the continuum of EMS. And as I hand it over to the hospital, I'm going to hand it over to my counterpart from Providence St. Pete's, and I'll let him introduce himself to talk through some of their data and some of the constraints that are in the hospital. Thanks.
Good afternoon, Board. Darren Goss, the Chief Executive with Providence Swedish, and thank you to our county as well. First, I'll go off script and just want to recognize the proclamation for Nurses Week. And that is our largest workforce of Providence with just shy of over 2,000 nurses in different capacities, whether nurse anesthetists, LPNs, or others. So thank you for that awareness. And for those that were here, it's a vital part of how we care for patients. So thank you. We had agreed with Multicare to just look at 3 metrics and kind of wanted to walk through those impacts. On the slide you see actually is our ER volume, and this was a little bit, as we've looked at since 2018 to 2022, we've actually seen a small decrease in our volume. And I think that's very counterintuitive of the experience that I think a lot of some of you or of our community members are experiencing. What is not on the slide is acuity. And so as we continue to see and look and advertise different ways of how to access healthcare. That could be through your iPhone, through virtual visits. That could be through express cares or urgent cares in partnership with Multicare. We continue to look at other avenues of how do we care for the community. Not everyone needs to go to the emergency room. We're seeing, we think, some of that improvement here with our volumes. But what's not on the slide then is acuity. So those that are coming into the emergency rooms do have a higher acuity that we've seen in the past few years. There is a misperception that if you call 911 to arrive in an ambulance, that you will go to the front of the line. And so we'll continue to work with our partners, law enforcement, fire, and others to try to continue to dispel that myth. We have days where we have almost no one in our waiting room, and we have days, and I know Commissioner Mejia and others riding with Medic One really do not have a great experience. And we have some wall times and wait times that we continue to monitor and look through. The next slide is just our length of stay, and this is within our hospital. As we continue to see that acuity rise, we're seeing the acuity and the length of stay in our hospital impacted as well. And so that does impact our capacity. Also here is our difficulties in discharging to lower acute care settings, so skilled nursing facilities, long-term acute care centers who also have some staffing challenges that the hospital has been going through. And so continuing to partner with Medic One to look for how do we bring on more patients, and really the goal is to get that unit back out in the community. And then the last slide, we just wanted to kind of look at the social determinants of health and those who do not have insurance and others, and that has stayed relatively flat for us. Multicare will show an increase in their areas, and we really appreciate that they're here in the market. It's another high quality option for our community, but we have seen this as far as those without insurance and others stayed relatively flat for us throughout the years. Our continued focus will be on getting units back out into the community. And I know Commissioner Mejia, there's some days that I'm really proud of our accomplishments and our turnaround times, and there's other days that we have a lot of work to do. So available to answer questions at the end of the presentation. Thank you.
Good afternoon, members of the board. My name is Will Calicot. I'm the president for Multicare Capital Medical Center and also the Thurston County market leader for Multicare. I've been in the community for a long time, about 25 years now, and I've been trying to think of the best way to come up here and not just say ditto to what my colleague Darren said. So a lot of the slides that are in the deck are very similar, and a lot of the talking points are also very similar to what Darren had mentioned. There's a number of initiatives that we're working on, at least within Multicare, to be able to address some of the constraints. And so just a little bit of context or history is we acquired Capital Medical Center on April 1st, no fooling, of 2001. Acquiring a hospital in the middle of pandemic is something I will never do again, but nevertheless, it was done. But job one was to identify what are the services in the community where there are gaps. And one just glaring opportunity was with the emergency department. And so we're actually working on a couple of strategies. It's kind of a two-pronged approach. One is in the now, how do we address the shortage of emergency department rooms in the community? And so we did break ground on a off-campus emergency department that's going to be in Lacey. It'll have 10 emergency rooms. That'll at least try to address the shortage of emergency rooms in the community, but that's prong one. At the same time, we're doing quite a few tactics to try and actually keep people out of the hospital, believe it or not. The emergency department is one of the most expensive cost settings in the world. And there are ways in which we can provide care outside of that expensive cost setting. So when you look at things that impact why are the emergency department visits going up the way that they are, a shortage of primary care is one of them. And so we are addressing getting more primary care out in the community, as well as Indigo, which is our urgent care platform. It's the largest urgent care platform in the state. But that can actually handle quite a few patients that would normally go to the emergency department. They can be treated in an urgent care. So we're trying to educate the community in all ways possible to be able to go there for care. And then the third is with Dispatch Health, which is another means to be able to provide high-touch urgent care in patients' homes. So it's just there's not one single lever that you're going to be able to pull to be able to address the shortage of resources, but these are multiple ways in which we're trying to provide more care in the community so that it's a better experience for those that truly do need emergency care in a hospital setting. Happy to answer any questions that you might have. Okay, thank you.
Any questions?
I guess,
There's a couple more slides going forward. If we slide up to public health, so I'm going to turn it over to Director.
Yeah, mine will be quick. Commissioner was had a question?
Yes.
well, I wasn't gonna let him off the hook that easy. I'm always one asking questions, but if David's got something, I want to hear it before I start.
Yeah, no worries. I think Ben and I just have a quick wrap up, and then you can grill them. So, mine's really quick. The slide data there is a bit older. I have some updated numbers, just really quick, just for context. So, I think the slides have 10 outbreaks listed on there in Congress settings, or up to about 40 over the last 2 months in that time period. But the trend over those 2 months has been going down. So when we're looking at those outbreaks in Congress settings, the number has been going down. So let's get back to the next slide. Really, the point of me being involved in this was just to note that, one, just the impact of a backlog in the long-term care facility arena impacts the bottom line when you're looking at hospitals as well. So if patients are stuck there, it has a ripple effect. And I will give lots of kudos to both DOH and Dr. A and their leadership over the last couple of months as we've sort of shifted how we've done outbreak management in these facilities. One of the biggest changes was moving from facility level quarantines to unit wing levels. It just was one of several examples there. And also just sort of thinking about like how we do things like guidance for enhanced mitigation measures, and making sure that facilities are coming up with plans that are still safe but are flexible when they're dealing with outbreaks. But ultimately, just wanted folks to see that this is not in isolation, right? So what happens in this arena and the role that public health has in helping to have this balancing act of safety, right, and also a flow of patient care is really critical here. And I'll turn this back over to Ben to wrap it up.
Sorry for the interruption, Commissioner. Just as a couple follow-up measures, I know we're anxious to get to questions. I'm going to speak very briefly to a couple initiatives that we're doing in partnership with both the EMS community as well as Providence St. Pete's to try to decompress some of those wait times. And then I'm going to hand it over for any questions you might have for us. In terms of what you're seeing up on the screen here, there's a couple different components that we're utilizing to help load level the system. Providence St. Pete's and Capital can provide a unique set of services, and to be able to utilize those services effectively, we needed to be able to inform our EMS providers on which facilities were available to them at certain times to help decompress some of the wait times. As you can see here, you'll see a running time that's available to all of the providers in the community to be able to look and see, hey, what's the current wait time for units outside of the hospital to help load level between Capital Medical Center and Providence St. Pete's to better utilize the systems during peak stress. On the right, I wanted to call out the partnership with Providence St. Pete's. There are 4 beds in the entryway of St. Pete's that EMS helps to staff. This is one of the more unique initiatives that have been done even in the region to help be able to put that unit's patient inside of the entryway, still maintain care by EMTs, but then get 4 more units back out into the community. Between January and February alone, the 7 weeks that we monitored it, we returned back to the community about 130 hours of ambulance availability. So in terms of a proof of concept, it was overwhelmingly helpful. We're looking at how we might maintain this moving forward to have that available. With that, I will open it up to any questions you might have for any of us. Thank you.
Any questions?
I'm gonna defer to the doctor first.
Well, I mean, as I think about it, I'm always like, in the community, you know, how do we recruit more of the care that we're gonna need? As you can see, the shifting of the demographics and the population. And I know in our practice, we've tried to always support teaching, you know, like so you can get people attached to the community. So I think, you know, obviously that's probably an initiative we should all support is, you know, teaching and being a welcoming community. But if there are other things we should be doing to really get all of those little pieces that fill up the gaps, I think that's what we most need to know.
Yeah, if I can address, we're kind of focused on a few things. One is housing, to make sure that's a piece here in Thurston County to make sure there's ample housing for staff. Second is just partnerships with South Sound Community College, Centralia College, St. Martin's University, and sponsoring education and training programs. Doing some training programs internally as well, just to help people achieve that highest outcome or highest job that they're looking for. But the way we've had to source and look for staff is very different today, especially around hiring, trying to be first to offer in other ways. We have to move real quick to try to retain in our community. I think that's probably consistent on both sides.
Yeah, it's probably doing all the initiatives that you're already doing about creating a vibrant community. I mean, if you're a physician in this country, you have your pick of anywhere USA that you can work at. We do have somewhat of a benefit that with Madigan here, a lot of providers retire out of the Army and then want to stay local in the community, especially on a beautiful sunny day like we have today. But it really comes down to schools, housing, and just a vibrant community in general.
Yeah, and I think we've all been like competing for the same workforce. So it's like elevating, like everything gets more and more expensive. And as a primary care physician, pediatrician, like for me to even get nurses has been a real challenge. I've got 5 amazing ones and I think they're just devoted to the mission and love kids. But, you know, I think we should all hopefully not take from each other too.
And I think that will continue to drive to innovative staffing models. How we care today for patients and team care is going to be very different in the next 5 years. And I know the Board of Health had some of our nurses present in December about the staffing bill that was at the state legislature. There was a compromise with hospitals and the union, so I'm pleased with that, surprised by that actually. But in that, it removed the critical ratios to allow that innovation. And that was going to be key for hospitals that we're going to have to look at other ways because there's just not enough nurses around. And I think we are all competing for the same workforce. So I think how we care is going to be very different in the next few years.
Ben mentioned the aging demographic that we've got and a growing population. I'm curious, throughout Thurston County, I think the coroner has dealt with over 150 drug deaths. Now, mostly that was fentanyl, but there were other issues in there. And 10 years ago, we might have had 10 during that same period of time. So with fentanyl being a big problem and the homeless issue being a big problem, is that a contributing factor to the overload that you folks are facing on a regular basis?
Yes, and I think those in particular, the volumes may not be as much as some of the other effects with the aging population, but the time and resources that are devoted to that one individual when they do come in ends up being where it's taking up a lot of resources for sure. Yeah, emergency departments are very resource constrained, right? And they have what they have, and they're there to be able to take whatever walks in through the door. And if that one individual is coming in with an overdose, that does take a lot of resources for sure. But the aging population is another very significant factor, at least when we're just looking at just hospital and acute care and emergency services. The aging population, self-included, unfortunately, is one of the most contributing factors.
Any other questions?
I have one. Are there other innovative models you've thought of, like your ER entryway work, which is really cool? I feel like through the pandemic, there was a lot of innovation and there were some things that we rapidly figured out that we had been wanting to do for a long time. Are there others that we should prioritize?
So I know that from an employer standpoint, there's other innovations that we're working on. We've launched what's called a physician in triage, and so we have an entire care team that immediately, as someone comes into the door, is able to start labs, start imaging, do an assessment real quick before waiting to be seen later, and then discover that that acuity is higher. And so we can move people through and at times not even have to bring them back because acuity level is low. So it's just changing our staffing models. And then I think just continuing education about there's other ways to access care. And I think to your point about aging, not everyone, so I've got aging parents, and my father's 85 and is not able to use the internet and do a virtual call, but I've got a mother who's very inept on that and how technology works. And so we're seeing that divide, and we're just going to have to continue to educate that there are other ways to access care, whether that's going to be in urgent care. We've stood up 3 immediate cares at all of our primary care practices, all in an effort to try to drive that volume away from the ER. So those who really do have an emergency, then we've got the right staff for. And that varies from time to time.
Do you think we could do better education to the public? Like just helping them, like, here's an urgent care visit, here's a call your primary care, here's a go to the ER or call 911. I don't
think we can never do it enough. And that piece, speaking of innovation, the other area, and I think that addresses the homeless situation in partnership with MultiCare and Interfaith Works, we've done a respite program. So Providence and MultiCare are purchasing beds within Interfaith Works. So if you do not have a place to be discharged to, but we know you need care, so it might be dressing wound changes or others, having you in the street, you will come right back to the emergency room. And so those are just some of the innovative pilots that we're continuing to explore to see where can we make a difference.
Well, thank you. I was wanting to relay my experience with Medic One because thank you, Ben. So I had a ride along with Medic One this past Wednesday, and thank you to Medic One staff for being very patient with me. And we addressed 2 calls. One of them was an overdose call, and shocking to see what an overdose looks like and just the care that it takes. And then the other one was just another victim, and they didn't know exactly what was wrong with him. So we ended up going to the emergency room. And so I got to experience firsthand what that backlog is and what it means to have, there was at one point 6 ambulances waiting, and that was, at one point there was a Yelm medic unit responding to an Olympia matter just because the other closer medic units were waiting, to be attended, for their patients to be attended. And so it was just, you hear about this wait time, but I don't think I connected everything until I was like actually there. And it wasn't like the emergency room was empty. It was absolutely packed, and the waiting room was full, and it was just, just everyone was doing the best they could to really get through. And huge props to Medic One staff and also huge props to Providence staff. I saw, even under a lot of stress, I saw nurses just being absolutely kind and helping people as they were coming through and getting their information and just really explaining to people what was happening and definitely helped lower the temperature. So we ended up waiting for around an hour and a half. And it was really surprising. But one of the things that, and I've spoken with Ben about this, and I was hoping Ben could talk about this a little bit more. And I know it's something that's Spokane is one of the areas that's looking into this. And I know that some of the staff were talking to me about this program too, especially with overdoses as they go into, if they said 1 in 10 people who go through an overdose request an ambulance to go to the emergency department, which I found, again, very surprising, those numbers. But usually what happens is when they go to the emergency department, the wait sometimes is very long. And instead of getting that triage and getting that care and getting the resources to combat addiction, they often end up leaving just because, they change their mind or multitude of things go into play into that. But there's a possibility of a care. And Ben, I was hoping that you could talk a little bit more about this because I think if I talk about it, I'm gonna completely butcher it, so.
You're doing an amazing job. I'm going to build off that just a little bit. So there's a couple pre-hospital studies that I'll speak to, and I'll call out that you were correct. It is an S drug, Suboxone, is something that they're looking at in the field, that if we can address overdoses at the point that they're occurring or just right after, we have a higher rate of acceptance that have been found in a couple different NIH-funded studies. This is still a sunrise, what DoH or the Department of Health calls a sunrise kind of pilot program is being done in Spokane and a couple other communities in terms of putting Suboxone on a unit to have those resources available at the time of the overdose. When Narcan is given, they have a conversation with the individual, and uptake in response to Suboxone is found to be directly proportional to the amount of time from the point of incident. That there's a higher uptake or a higher willingness from the candidate to be a part of that component in terms of being able to address the addiction. So,
Thank you.
yeah, absolutely.
Any other questions or comments from the board? Yes.
Yes. If you had to take just a guess about how many beds are occupied at any given time that otherwise, if there was a space to release them to, turn them, whether it's a house or some lower level of care, how many beds at any given time are tied up in your facilities by individuals that should be really released and there's just nowhere for them to go?
Yeah, I have that number. We look at that daily.
Oh, okay.
So with over 400 beds, we're just shy of 40, so about 10%. Have no medical, let me rephrase that, do not require the high level of medical care that's provided in a hospital. And so those are continuing to work with skilled nursing facilities and others, not a large space and not a large market here in Thurston County in that space. And so Providence does have Mother Joseph skilled nursing facility that we work with, and our goal is to continue to make sure that that's at capacity.
Out of that 10%, is it possible that, I don't know, maybe half of those folks maybe are homeless and could be released if they had a roof over their head, so to speak?
Yeah,
And maybe the other half maybe need to go to lesser care?
I don't know that answer. I don't know.
But I mean, it must be some kind of a breakdown there, I suppose.
We could look at that and get back with you.
I'm just trying to figure out how we formulate a solution.
Yeah. Yeah, I definitely would encourage us to look at the data around that. We do break down, we call it barriers to discharge. Here's how many people that have a barrier to discharge, and here are the reasons why. Homelessness, I would not predict it to be 50%. There's other challenges, regulatory challenges, rule interpretation challenges by the Department of Social and Health Services and others that limit our ability to discharge home. And then there's others where it's just, it goes back to the staffing, and everybody is clamoring for staffing, and skilled nursing facilities are not excluded in that. And if they don't have staff, they might have a bed, but a bed is useless without a nurse, right? And so we can't discharge to a skilled nursing facility. I would contend that there's other, not to diminish the homelessness, that's definitely a challenge, but proportionately, I don't think that's gonna be 50%.
Commissioner Mensah?
Oh, I was just gonna tell you today's gonna be.
Thank you. When you guys presented to the Board of County Commissioners, and Will, you weren't there, but I'm gonna ask, we talked about the Medicaid rates and how they hadn't been updated in like 20 years and how that was impacting several parts of the system. One of them was long-term care facilities. So I'm kind of piggybacking on the question asked by Commissioner or Board Member Edwards. Can you talk a little bit about how important of a piece that is to the system and this backlog of not having anywhere to discharge folks who need discharge? And then what are the solutions? Like, is it, I know that there was a bill or something was going on in the legislature this year that didn't get to the finish line. Do we need to, what can this Board of Health do to, get us to the finish line or help? Is there something that you can think of? Should we prioritize this? In what ways could we be effective in trying to, create solutions? Because, this just seems to me to be an unnecessary piece of this complex puzzle. This one can be solved. So I'm hoping you can provide some insight.
Yeah, thank you, Commissioner Mensah, for the partnership. Our actually MultiCare's mission statement is partnering for healing and a healthy future, and the county is definitely a key partner in that. And I think you're right to some degree that collectively as a society, this is a self-inflicted wound, that we want care, we just don't have the ability to always pay for care. And so if there's been, you referenced a key statistic where in the last 20 years, 20, there's not been one rate increase in the state from the state of Washington for Medicaid. And as more and more patients are on Medicaid, we've expanded Medicaid, which is great. We provide more coverage, but coverage doesn't equate to access. If you're not going to pay providers at least their cost for providing care, there's going to be limits in the ability for the community to be able to see those patients. And so all of that does add up to it. To be quite frank, I might lean on my colleague here. We're still learning from the what happened out of the legislature. Are there maybe pockets of funding here or there that we might be able to access? But the state funding piece definitely would, as we ramp up to the next legislative session, look to partner with the county for help on that.
Yeah, I'd even like to recommend, I'm not prepared, Commissioner Mensah, to have my top three, but if it's all right, that we could work with Medic One and the county and bring back some recommendations. The state legislature session is closed, and so this will be for next year. But perhaps we can collectively with MultiCare come forward, have some discussions, and then bring back some recommendations for the board to consider.
As a follow-up on that, we have a lobbyist that does a lot of our work when we have issues in front of the legislature. And I suppose there's a hospital association lobbyist so if we team up, you guys can be the experts and we can say, hey, we really need it, kind of tag team them or something. But I think it'd go a long ways towards maybe being successful, because I'm going to look towards the county manager right now, but I don't recall that we did anything on this front this year.
No, we didn't have any specific bills.
And I mean, we had our hands full on our own thing, but we would gladly participate in supporting your needs, because your needs are our community needs. And our community needs everything that we're not giving them. So it would behoove us to get together. Looking forward to that. Thank you very much for your presentation, by the way.
I have one last final question. For the entry staffing, did you guys have an idea or suggestions on how to maintain the entry staffing process or protocols?
Yeah, I think, so staffing, there's really two levers. It's acquiring and then retaining, right? And this, to your question, it's around the retention, especially as entry level, but quite frankly, all the way on up. There are different ways in which we, try and ensure staff feel valued and heard so that they want to stay. But yeah, it definitely is all hands on deck when we look at every day, what's our turnover ratio? How many people did we bring in? That's great, but also how many people left and why? And what can we do to be able to address that? Especially as we're coming now out of the pandemic, the burnout and other factors that went along with them going through that, for sure.
Thank you. Any other comments or questions from the board? All right, thank you.
All right, thank you.
Thank you.
Ben, I knew it started with an S.
Next item on the agenda, Health Officer's Report, Dr. Goss.
Good evening, Board of Health. I wanted to start by thanking the folks who spoke earlier and shared their perspectives with us. I also wanted to share a little bit about COVID-19 outbreak mitigation measures in Thurston County. So in general,
Dr. Ray, could you? Thank you.
Perfect. Thank you. So I do want to share what constitutes an outbreak in a school setting, and that's when 20% of a classroom gets COVID-19 within 7 days. And so when we're looking, and there has to be evidence of of transmission within that classroom or cohort. When that happens, the way to bring down transmission is both testing so that we're detecting cases early. And the other way to bring down transmission is through masking, which contains droplets, droplets prior to their being spread to other folks in that particular cohort. We use this in schools. We give similar recommendations for workplace outbreaks where folks are coming into repeated contact with each other. And there's evidence of spread. Congregate settings, so these are the mitigation measures that are kind of the backbone of outbreak response for COVID-19. I did want to share a little bit about where we are at in general in our county, where overall things are looking better as far as COVID-19. So we're at 26.1 cases per 100,000 over the past 7 days and 55 cases per 100,000 over the past 14. The majority of these cases in Washington are due to the XBB.1.5 variant, although there are other closely related variants that are increasing in prevalence. The good news is that even with the change in variants, we're not seeing a spike in hospitalizations or deaths from COVID-19. So we had about 2 patients who tested COVID positive and were hospitalized per 100,000 over the past 7 days based on the CDC. And COVID-19 positive patients in Thurston County account for less than 5% of staffed inpatient beds. I did want to share a little bit. So there have been a lot of changes since we last met. Some of these changes have been changes in vaccination for COVID, where we no longer, where we've transitioned to an updated bivalent COVID vaccine, and the monovalent Pfizer and Moderna vaccines are no longer used. That's a big step. This means that folks are now up to date. So the vaccine schedule got a little bit more complicated with this change. The the biggest two changes were everyone 6 years and older is considered up to date with one updated or bivalent Pfizer or Moderna vaccine, which is pretty significant. The second big thing to share is that folks over the age of 65 may receive an additional bivalent booster 4 months after their first, and folks with immunocompromise can receive an additional bivalent booster 2 months after their previous booster. So there's approval for that second dose for folks at high risk of severe disease. The recommendations for folks under 6 are a little bit more complex, and I definitely defer, for folks that are wanting to support their kids and grandkids in immunization to check with their healthcare provider. To see what vaccine is the right one for them. I did also want to talk a little bit about the end of the public health emergency for COVID-19 that's coming on May 11th. There are some aspects of what we've been doing that will change with the end of the public health emergency. But in Washington, for most folks, we anticipate a lot of continuity. So COVID-19 continues to be a notifiable condition in Washington state, which means that healthcare facilities, laboratories, healthcare providers, and specific reporters like schools and daycares will continue to be required to report positive cases to local health jurisdictions. There is specific guidance from BoH and CDC regarding mitigation measures and precautions. As these things change, I know that a lot of the guidance is under review. So as we transition from COVID being in the foreground to the background, we do anticipate seeing some changes in those guidelines as well. I did want to share some of the key things that will also continue even after the end of the emergency. So in terms of, we anticipate continued access to federally purchased vaccine at no cost, as well as federally purchased therapeutics. We do anticipate commercialization in time, but we're looking ahead, towards, end of summer or fall at this point. The other big changes are that insurers are no longer required to provide COVID-19 tests at no cost. The Washington State Department of Health is, we're still looking at the state level to see what additional testing resources might be available for those in need going forward. So more information to come there, but there are folks looking at that, especially thinking about schools, shelters, and places where access might be a challenge. With the end of the COVID-19 emergency, some of the data that's been reported throughout the pandemic may not be reported to the CDC. The two measures that folks might first might notice is that the CDC won't calculate community transmission and levels, which was primarily used in the healthcare setting. And at this point in time, it's thought that they won't be calculating community levels, but all available data will be available. All of the reported data will be available at the CDC COVID-19 data tracker, so folks can keep track of cases, hospitalizations, and things of that nature with all of the data that continues to be reported at the national level. So this is a dynamic time in the pandemic. We have come in an incredibly long way from February of 2020. While COVID-19 is still here, folks, we're still, it's still circulating in our community, and it's something that we need to be mindful of. We're in a much, much, much better spot, and I'm looking forward to continuing to work and support our community as we move through this next phase. And with that, I'm open to any questions you may have. Thank you so much.
One question. With the end of the COVID emergencies and knowing that things are changing, and we have an outbreak such as one at the school, is it a recommendation or a requirement for masking?
So, actually, the health officer is responsible for controlling the spread of communicable disease in the jurisdiction, and is responsible also, together with the local health jurisdiction, for providing guidance in the setting of an outbreak. At this point, so when we see an outbreak, so in the school setting, that's 20% of kids in a cohort getting COVID within 7 days, with evidence of ongoing transmission in the classroom setting. We send written guidance, which is a health officer directive. If mitigation measures aren't taken, then we consider other options, but we always start first with working with the school, working with the community to support folks in taking the measures that are needed to slow transmission. I did also want to share in a related vein that sometimes, so the backbone of outbreak response is masking and testing. Sometimes a facility or a school or a group may elect to be more conservative when they're looking at their community needs and their staffing needs, and they may choose of their own volition to close in response to protect the safety of folks that are at the school. But as far as the health officer directive, that really is mostly masking, testing, and just preventing transmission and supporting folks taking, we of course support folks in our community to evaluate their situation and take necessary safety measures.
Board member Evans?
I guess I would just follow up on that same question with, well, first, maybe, what is the data in comparison to the flu? You gave some is per 100,000 on COVID, but how does that compare to just the flu or serious cold? I don't know, but I would think we're having a lot more than that of flu and colds, aren't we?
That's a little bit of a challenging question to answer. So influenza transmission in Washington State right now is minimal. For influenza. So COVID-19 is a reportable condition, meaning that laboratories have to tell us. That we have some great providers in Washington State that when they do like a multiplex study and test for other viruses, respiratory enterics, will share it with the state. And that gives us overall trends and trends for things like RSV, rhinovirus, other respiratory illnesses are downtrending, but because it's not mandatory reporting, that it's a little bit hard to compare hard numbers.
I guess my concern with the communication that we had from two citizens today is that I'm more concerned about disrupting the learning process than I am about their possibility of spreading this and having more dire effects from this. So getting back to the vice chair's question on that, what is the authority that, or what is going to happen if this school says, well, it's not a mandate, it's a suggestion, and we're going to disregard this letter because we don't think that it's appropriate. So what happens? Does somebody get thrown in jail, or what are we going to do about that?
So in general, we work with the community. I think I think a number of folks in our community do understand the nature of the outbreak and the impact of being sick and sick days on children's learning, where they need to be absent from school if they get sick. So there's some disruption there. Even even from other exposures. And exposures within the classroom and if mitigation measures aren't taken. So these mitigation measures really are trying to maximize the amount of healthy time kids spend in school. If the recommendations or if the directive isn't taken and there's a threat to public health, the next step is a health officer order, which is a requirement.
Well, isn't this letter that they received, isn't it a health officer requirement? It says, the letter says, if students and staff that are exposed, says they are required.
Yep.
And to me, are required takes away that ability to make decisions on their own. So that's what I'm wondering about. You're alleging that it is not required, it's a directive. What's the deal?
A directive is the health officer informing a group of folks of what they need to do. A health officer order is legally enforceable.
And then what happens in 2 days when it's all done? May 11th is the end of the pandemic. 2 days aren't gonna make any difference mostly, but legally, 2 days go by, now what happens?
So these are two separate issues. So the health officer has a responsibility together with the local health jurisdiction to mitigate outbreaks. And that's actually in our WACs, and I can pull that up. It's not tied to it's not tied to the public health emergency.
But you could do this 6 months from now? Could this be a never-ending way we're gonna treat our kids?
So that's a question that a lot of folks have been asking, and I know that we, as a public health community, that's something that we're considering and looking at pretty carefully, including folks at the federal and state level. So as COVID moves from the foreground to the background, as it moves from pandemic to endemic, meaning that it has predictable circulation and transmission patterns within a population, I anticipate that the guidance will change to reflect the situation on the ground. I know that there are a lot of folks that are looking at what the timeline might be and how that process might go going forward. So in terms of outbreak mitigation, yes, that is a standing responsibility for the health officer, not just for COVID, but for communicable diseases, especially notifiable conditions writ large. But as far as COVID in particular, right now we're at a time where folks are running the numbers and reassessing and are reviewing all of the guidance. So would this happen, right now, this is what's necessary to control the spread of COVID-19 and prevent more kids from getting ill. And if, as things change, we also evaluate our local experience as well as the numbers and change.
Okay, I don't want to hog the show.
County Manager Romero?
Yeah, thank you. Doctor, absent the emergency ending, and I think you described the responsibility of the health officer to, control any outbreaks. I think that the conversation is narrowed down here to COVID-19. But it's the same approach, it's the same responsibility. I think you briefly touched on other outbreaks that you have the responsibility to control. Can you touch base, because the strategies in controlling outbreaks outside of the COVID-19, the health officer has the responsibility to control, and tuberculosis, for instance, or any other notifiable conditions. That's the responsibility. So, and I think you're trying to separate between ending the emergency of COVID-19, but the responsibility of controlling the spread of communicable diseases continues to be in perpetuity.
Yes, thank you so much, County Manager. That's true. We do control the spread of a number of communicable diseases, both through mitigation measures, where appropriate, thinking about, influenza outbreaks in long-term care facilities. We also, use isolation for folks who may be contagious. So, folks with active tuberculosis, are required to isolate at home so that they don't infect other people. So, but it's one of the parts of my responsibility, as a health officer that I share with other health officers in Washington.
Are there other questions from the board?
Well, I guess what I would just say is I think we're all in this transition zone and we're all trying to navigate what's best for everybody. And I think schools, obviously we learned mental health is not good when you're out of school and learning is not good when we're out of school. And so I think we also want to keep people safe. So if there's a measles outbreak, you're probably going to say, we need to do something about that. If there's a norovirus outbreak and everyone's dehydrated and vomiting, we're probably going to have to do something about that. And so I think this is sort of what we have to figure out with COVID, and just know that like moving forward, we're going to still have times where you like might have an influenza A outbreak and that's going to impact your school or something. But I agree, like this anticipation of the risk of COVID, I think we should have a uniform probably approach. And I'm sure you feel like that too with schools, like keeping that safety of staff, safety of students versus risks of not having them in school. And so I just want to reflect that we're all confused right now. It's all very challenging, and like trying to assess that risk is a day-to-day, moment-by-moment situational assessment probably.
And I did.
Commissioner Mensah, you have your hand up.
Yeah, thanks. Well, I see asking for masking and testing far differently than what we had before when we had to close schools. And that's not a decision I would take very lightly, but this is just seems to be, if you've got it, I had not heard that standard before tonight. And that seems like a pretty high standard. 20% of a classroom of students within 7 days getting COVID, that's a pretty serious situation. And in that situation, asking for masking just seems like common sense. But I did want to ask about when it comes to COVID lethality, I guess I'll use that word, death rates. I mean, your report didn't say anything about that. And given where we are with the pandemic and the type of variant that we've got circulating and the vaccination rates that we have in our community, has that changed or lessened, or, the number of cases that result, the number of cases that we have, and then you said 55 per 100,000 per 14 days, that's on the lower end of what we saw during the pandemic, but it's not like, it's not zeroed out, right? That's still significant. And I guess I'm wondering, are fewer people having that sort of, worst case scenario? Where are we with that? Because that kind of plays into this whole calculus.
Yes, so the good news is that we are having fewer folks overall that are being hospitalized related to their COVID-19 and dying from COVID-19. There's obviously a lot of variability where folks, over age 85 and folks that are older are at a much higher risk of death and continue to be at a much higher risk of death from COVID-19. Folks, who are who are significantly immunocompromised also are at increased risk of severe illness and death. But we're in a much better place. Just thinking back to the Delta wave, where there was where we would see many more deaths associated with our long-term care outbreaks than we're seeing now. We are, in terms of disease severity in a better place than we were. However, the current circulating variant is much more infectious, so it's much easier to get COVID, even if the risk of severe illness from getting COVID on an individual level is significantly lower than it was.
I'd like to just add, I appreciate some of the comments that have been made here. We all want kids in schools, right? But if 20% of, and while the risk of death and hospitalization is much lower, it's not zero. And we're seeing some pretty, I'm not gonna be able to quote statistics, but some pretty scary numbers of cardiac disease, clotting disorders, a rise in diabetes in children. So the risk is not zero. We all want kids in school, but if I'm in a classroom and 20% or more of those children have active COVID, or my child's in that classroom, I think, as Commissioner Menzer said, masking and testing are not unreasonable accommodations to make to keep everybody safe. So I really thank you, and I support the work that's being done.
Well, and I think we also don't know the long-term impacts of COVID still. And there are like these long COVID cases that are really weird, inflammation throughout all sorts of organ systems. And what is that impact going to be long-term on people? We don't really know. So I agree, like, to me, masking is nothing. I do it all day long at work all the time. And I think kids are pretty adaptable. We found that like 2-year-olds will wear a mask. Like you just make it fun and teach them and know there's an end in sight, celebrate it. So I agree, like, and at 20% is a lot.
That's
and like
big number in a classroom full of children.
Yeah, so
And I just wanted to reiterate that the goal of the masking and testing really is to keep people safely in school and to try to balance, folks' social needs with, along with kind of mitigating the health risk of COVID.
Any other questions or comments from the board, the audience? All right, thank you.
Thank you.
And I move to adjourn the Board of Health meeting for May 9th, 2023.